Assalamu alaikum and good afternoon. I apologize. I think Dr. Weil had an earlier flight to catch. It's my pleasure to introduce my colleague, Dr. Abdulrahman Alqahtani, who's the director of the cath lab in King Salman Cardiac Center, who's gonna show us an interesting case titled A Tough Nut to Crack. Abdulrahman, the floor is yours.
Thank you, Dr. Faisal. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Just for those who have seen the live case yesterday for the structural TAVI case, just a follow-up, because we closed the case before we give you final feedback. So there was a thrombus at the end of the case, and basically there was question if this is just a pure thrombus. So we thought it was related to a dissection. So as you can see, we've ballooned that, and this is the final result. There is a dissection that is non-flow limiting, stable. Those patients we don't touch. So this is basically the follow-up for the case we did yesterday. We left it alone in peace. So we're starting with you. This is a life-in-a-box case that for a complex coronary artery disease. Excuse me, there is a promo video. Is there a promo video running? No, just before. Can you run it now? Yes. You can start the case.
Everybody, this is Dr. Abdulrahman Alqahtani, Head of Interventional Cardiology at King Salman Heart Center at King Fahad Medical City. Today, I have the pleasure of working with my colleague, Dr. Fahad Alqahtani, who is one of our pioneer interventionalists in our cath lab. I'm joined by a team composed of a scrub nurse, Lu'ay Hassan, also our CVT, Abdulrahman Swayih, our X-ray, Abdulrahman Hafid. We have our two lovely nurses at the back, Rinjo and Aisha. Both of them will be supporting us through this case. We are privileged and thankful to GIS and to the sponsoring Medtronic company for allowing us to share our experience with this complex case. We have the pleasure to introduce you to our patient here. He is an 80-year-old gentleman with a background of dyslipidemia, hypertension, type 2 diabetes. This patient was well and highly functional until now, until 2 months ago. He started to have inguinal symptoms and presented to a hospital in the central region with chest pain. He was found to have non-STEMI, and angiogram in that hospital revealed approximately tight lesion in the LAD, as well as heavily calcified lesion in the mid-LAD. An attempt was done to open the LAD, but due to difficulty opening the mid-lesion, they stented the culprit lesion at that time, the proximal, and they left the rest for planned stage BCI or medical therapy. The patient continued to have symptoms and therefore presented to a hospital in the eastern region where they attempted to open the mid-LAD lesion with no success. He presented to our emergency department with active chest pain, mildly elevated troponin, and admitted as a case of acute coronary syndrome. We're about to share with you now his angiogram. Of note, his LV function is still preserved. His ejection fraction is 60% with no significant valvular disease, and his coronary angiogram will be shown to you next. This is the angiogram. We're showing you here the approach. We elected to go femoral approach, anticipating difficulties in the LAD. This is a diagnostic JR through a 7-French system. What we can see here that the RCA has a lesion in the mid-segment that is already stented. The information is not pertinent, is not available to us at the time we saw this patient. His hospital did not provide the information that we could elude when was the stent inserted. But according to the patient, nothing was done before 2 months ago. So I assume was his presentation. the LAD stent. Next. What we can see here, this is an EBU 3.5 guide 7 French through a femoral approach. And the left main is very short in this view. We could appreciate the LAD is almost subtotally occluded in the mid segment. There is a heavy calcification present after the stent that's present in the proximal LAD. Also, there is significant disease in OM2. Next. We could appreciate that the lesion in the mid LAD is heavily calcified, and there is significantly diseased ostial D2, which is a sizable branch as well.
Just want you to pay attention that the second branch, the OM2, is almost subtotally occluded. It's for great importance later on.
The rest of the LAD distally looks very sizable and free of significant disease. Next. This is an areocranial, and you could appreciate the size and the caliber of the D2, and you could appreciate also the complexity of the lesion given the degree of calcification. We will zoom on the mid-segment of the LAD to show you the degree of calcification. On a closer look at the mid-LAD, you could see that there is a degree of calcification with looks to be circumferential. We cannot say for sure without having a clear imaging, which is difficult to obtain at this stage of the procedure. Next.
Abdulrahman, do you have the option of pausing the case so we could ask questions?
Yes.
Okay. So far we have seen a complex case, visited 2 hospitals, and now he's in your hospital for a complex procedure. At this stage, did you have the chance to look at the mode of failure for the previous operators?
No, so according to the patient, the information that's provided to us, that they could not, they was told that the lesion was very strong and they could not open it. So I'm assuming that it was not yielding with balloon angioplasty for them, and they did not have debulking
So
modality.
crossable, but they are not able to.
Yes, they crossed according to what I've understood from the patient. We didn't have a report at that time, but assuming the story with that, they tried balloon angioplasty and they failed, and they did not have debulking.
So can we go over your choice of access? You elected to go 7 French, better support versus radial.
So anticipating that 2 hospitals have already attempted this patient and both of them could not achieve success with that, it would be a complex, very complex lesion. So we went femoral 7 French in this patient from the get-go. In anticipation that we will do debulking in this patient. So we wanted to have better support, a bigger guide, and something to work with in case we face troubles.
And a final question, what was your strategy based on what you have seen so far in the angiogram?
So our strategy was basically mainly to attempt to open the LAD with debulking. We were planning to use imaging in a form of IFUS in this patient to determine if this would be just a rotoablation case or we need to do a shockwave therapy as well. And that was the plan, and to see if we could open any side branch, especially that subtotally occluded D2. So our plan was, if we managed to open that, it would be still provisional techniques in terms of stenting. So that's what's our plan, on top of fixing the OM as well, the plan to fix the OM as well.
May I ask the floor, if anybody have a question before we go into the details of the case, please come to the mic. Feel free to ask any questions. Go ahead, Abdulrahman.
Okay. So I
The
think
left main is short, and we do not appreciate any significant disease there, but we could appreciate the disease in the OM. And we could see the stent in the LAD is widely patent, and there is no significant disease within it. However, there is haziness in the proximal segment of the LAD just before joining the short left main. Okay, so we elected to approach those lesions in 2 steps. The first step was to address the significantly diseased large OM2. We passed both wires, BMW wires, and we start by pre-dilating with a 2.0 compliant balloon, and then 2.5 non-compliant balloon. And then we deployed a long 2.5 by 32 Onyx drug-eluting stent. Okay, next. Okay, next. This is the artery. This is this after post-dilating before deploying the stent. and we deploy the stents in this view just to make sure we don't protrude significantly into the LCX. Next. And this is the stent deployed. And next, we post dilated with 2.75 NC balloon at very high pressure at 24. The area was very difficult to cross at the beginning, but once we started opening it, there was no issue. Next. Okay, next. And this is the final images of the LCX. We pulled the OM wire and place it in the LAD. So,
May I ask you, Abdulrahman, to pause for a second? Thank you. Great result. Can I just show a show of hand? Who would have started with the OM or who would have gone directly to the LAD? Anybody who would have started with the OM? Yes, I'm assuming the rest would go and directly fix the more complex lesion. Great. Go ahead.
Maybe who would fix the OM? On who?
Fix the OM before the complex PCI. Okay, so you have good supporters.
Okay.
And who would have just go and fix LAD and then leave the? So I will say it's more favorable towards the LAD. Go ahead, Abdulrahman.
Okay.
We managed to wire the LAD. We left a wire in the LCX just in case we had to come to the short left main. We need the protection of the left circumflex artery. But what we face is very difficult crossing of the second diagonal artery. You could see in this view that we have a microcatheter and we have our regular BMW wire, and we were planning to use different wires either in a form of fielder or whisper, but I managed to cross it after bringing the microcatheter very close to the ostium of the diagonal branch, and you can see this is my BMW wire. So once we give it the tip more load using the microcatheter, we managed to pierce through that plaque and advance our wire distally. So next. And we started there by basically doing balloon angioplasty. So we used here at the beginning first 1.5, and then we used 2.0 next. And we opened this very well, but you could see that the LAD went down on us, and patients started to have ST elevation MI at that time.
So patient became very stable after we opened the diagonal. The LAD went down, so we went ahead after
and
the
we went
LAD.
and did balloon angioplasty to the LAD to open the flow. And once we established that, patient stabilized. Next, next, and next. This is the LAD. Go back. This is the LAD after we opened the diagonal. You could appreciate how sizable that diagonal is. And you could see the LAD, and there is evidence of dissection.
So Abdulrahman, did you need to debulk here? Did you need to debulk, or you crossed and you dilated?
So we, when we crossed, we used started with a small balloon in the diagonal branch because I was not planning to stent the diagonal. The plan is to remain provisional. So I wanted to just open the diagonal and then basically try to debulk with a microcatheter in the diagonal through 7 French. It didn't work, so we had to take everything out.
Then try to advance IVUS, and this is a Boston Scientific IVUS catheter, and you could see we could not basically cross that small IVUS catheter across the LAD. So we are going to continue now by doing rotablation to the mid LAD using 1.5 per.
So we decided to go with the rotablation, as you see, heavily calcified lesion. So what we use here is a RotaPro, the new system of rotational atherectomy. And we find.
Despite our best effort to keep the the microcatheter in the diagonal, we could not do that.
So this is one of the things. So we had to open this side branch, and we wanted to protect it. And in order to do rotablation, there is also the idea that you can put just a microcatheter. It's not going to be affected by the rotablation. Even though it's 7 French system, we could not advance the rotablation device or burr in the presence of the microcatheter. We had to take it out.
Therefore, in order to achieve debulking technique in this patient, we should just take everything out and just keep the rota wire, and we will now start rotablation. Okay, so we're starting rota. Okay,
So may I ask, Abdulrahman, would you rather, or did you decide to burr proximally, or would you in
So we started just within, likely within the stent, just before the lesion. We did not touch the proximal LAD.
How fresh is the stent?
The stent is almost now 2 months.
Okay, So you could see the deceleration, but we don't want it to be stuck. So we crossed now the lesion, and we can come back and stop, okay? So normally we would like to go for about 15 seconds, maximum 20 seconds. We start with 6 to be able to break through this lesion. We're gonna give it 2 more rounds, and after that we're gonna do imaging and take it further from there. So now after doing 3 runs of rotablation, we're gonna take it out. The best way to take it out is using Dynaglide. It's a lower speed and allow the burr to rotate and allow it to come out faster. So go. Hard minori flow or slow flow after the rotablation. We're gonna take a picture and then show you what's happening next. So now we finished rotablation and we exchange wire. We managed to rewire our diagonal without any difficulty. And currently where we go.
So even though we had to take our wire and microcatheter from the diagonal, after doing rotablation, we managed to wire that second diagonal.
What we want to do is basically our plan for that diagonal. We're going to show you the picture with the contrast. We're going to first do IVUS to the LAD, appreciate the size and the proper management from an interventional point of view. Okay, so let's just fill with contrast. Ready? Yeah, fill it with contrast. Okay, so we're going to take a picture now. Go ahead. So we could appreciate now the whole size of the LAD.
So this is our result after the debulking. We'll show you now the IVUS.
At 3.0 to 3.5 mid LAD, approximately maybe up to 3.75. We're going to convert that with IVUS. And you can see the diagonal is widely open now. There is a significant stenosis there. We'll try to do dip and see what's going to look like after that. And if we have to commit to a stent, we'll consider that.
So your strategy now, Abdulrahman, is still provisional stenting, maintaining the diagonal open. Hasn't changed.
Sure. So this is the IVUS after the debulking.
Descending coronary artery starting distally. You can see the vessel with the minimal mild disease, and we go in more proximally, and you start the atherosclerotic plaque coming. And here we start the calcified plaque coming in, and you see this is the diagonal branch, heavily calcified, and now you start to see the calcification. This is more than 180 arch of calcium, going more proximally into the mid-LAD, and now you start seeing the proximal stent in the LAD. It's well opposed, 3.0 size stent.
لبيك خلصنا تحس
And then we're going back to the ostial LAD, back all the way to the left main. Then now we're going to see our distal reference area. Our distal reference area is 6.33 MLA and a diameter of 2.65 by 3.0. So we'll choose the 3.0 stent and going more proximally. This is the proximal reference area. This is the stent. We're going to overlap the stent, and the stent looks like it's a 3.0 stent. And some concern regarding the ostial LAD, and the area of the ostial LAD is 7.63 millimeter square with a diameter of 2.75 by 3.39 millimeter.
So we followed our plan of doing.
We're just going to ask a quick question. When you did the ultrasound, how was the success of your debulking in relation to the calcium?
So you could see still there is ring of calcium, but we had cracked the calcium in multiple locations. We already tested that with the NC balloon after that, and it was expanding well. So we were not concerned. We were ready to go. And
just a reminder about the distal lumen. How much the distal lumen diameter?
It was 7 point something. Unfortunately, the numbers were not showing. It just the run itself. So this is this is important part. So we decided at this stage that the diagonal, we'll leave it alone. We'll just do a drug-eluting balloon, and then we'll just cover the LAD with the 3.0 stents, okay? So this is a drug-eluting balloon, 2.5.
To the side branch and stenting the main artery, the LAD. We used 2.5 drug-eluting balloon by 15. And as you can see in the picture in front of you, this is where we inflated. We inflated a little bit distal, but you could see there is no full inflation in the mid-segment. After we did this and we noticed some changes in the ECG, bradycardia, I was worried that we might have a rupture, that the patient was not behaving the right way. Next, show us the next image, next, here, and this is what we see. So we see a very large extravasation, mushroom-like appearance in the mid of that. This is class 3 to 4 perforation, and therefore we had to work quickly in this situation.
So this was unexpected, to be honest. We had balloon this with NC, balloon 2.5, we had no issue. And we were just doing the drug-eluting balloon. Drug-eluting balloon is not very high pressure. We were going up to 6. So we were not expecting that, but then this happened. So our aim and our goal was to work on the LAD, and now we faced this. Maybe we decided at this time to cancel the case, but since it's been recorded, we had to continue.
We took a balloon
I think I heard you saying to the patient, "Khalas, khalasna."
We were.
That's a warning sign. But it's very interesting where the perforation happened. It's not in the calcified segment. In fact, towards the distal end of the balloon. Do you mind just?
Yeah, I'm gonna play it back a little bit.
Like appearance in the mid of that. This is class 3 to 4 perforation, and therefore we had to work quickly in this situation. We took a balloon back and we inflated across the site. Next. And we kept that for about 5 minutes. Next. That will give us some control. We could see there's still a flow in the branch of that diagonal. Next. The patient stabilized. We did a quick echo. There was no significant pericardial effusion, and until now there was no signs of tachycardia.
May I ask Abdulrahman to pause because I really need to take a poll here. So Abdulrahman kept his cool, and you could hear it in his voice. Balloon is inflated. He did not. It doesn't look like you put a pericardial drain.
No.
Everything looks okay. May I just, with a show of hand here, how many will leave the balloon inflated and get a stent and stent the LAD? Okay, so at this stage, people will definitely leave the balloon open, inflated, and just finish the job with the LAD. Anybody will stop the case now and just see what is the consequences of the perforation? Okay. Okay. Go ahead. Go ahead. What we are asking would you, at this stage, leave the balloon as it is? You have a 7-French system, get a stent in the LAD, and I think multiple people raised their hand. Or would you, at this stage, stop and just see what is the consequences of the perforation?
A third option is to deal with the perforation, take a breath, and go for LAD.
Okay, fair enough. Go ahead.
So just to follow that, so would anyone inflate a balloon and stent across a balloon inflated?
No.
Oh, so you're not suggesting that?
No.
Okay.
No.
Just
No,
to clarify, because
the point
it sounds
is,
like
some
your
people
balloon is
will
up and you
say,
wanna
some people will say, you have a 5 minutes inflation.
Yes.
And basically get your stent ready. You have a 7-French system.
Yes.
And if you don't have, pull the balloon, leave your wire, stent across.
Yes, okay.
So we did multiple inflation. We tried to advance covered stent. Unfortunately, we couldn't due to the fact that there was difficult.
So we actually, we did the balloon inflation for 5 minutes, then another 5 minutes, and you will see there is a little bit of extravasation remaining. So I wanted to cover that. So we brought a Piper's covered stent to the same size of vessels, 2.5, and then I took it even smaller. But then it will not take the two different angles. It was going down, up, and down again. So it will not take that. And we almost degloved the cover stent because of that. And we could not deliver the cover stent. So showing you what's happening right now.
Stent, you could see we used a guide liner to try even to advance our cover stent with no luck. But then we took a picture. You could see most of the extravasation resolved. There is only small amount. And then we applied more balloon inflation. Next. Next. And then we elected after that to basically next. to stent the LAD and see how things goes with the LCX, with the diagonal next. And so we took the guideliner out. This is the picture before we stented.
So this is what the artery looks like now. So enormous extravasation after 10 minutes of basically, can we go back?
Can you go back time, please?
As you can see, the artery was fine, no issues, and there is no significant extravasation. Next. So next. So we used a 3.0 based on the IVUS sizing. The distal artery size was about 3 millimeters, so we used that. 38 onyx drug-eluting stent. We deployed that. Next. Next. And after we deployed, we lost the artery completely. Next. 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 So we did post dilatation, and then we took a picture. Next, Abdullah. Next. Next. And this is our final picture.
So after we stented the diagonal, we had black shift. There was a lot of calcification there. We lost the diagonal that we worked so hard to open, and then we lost it now. So I think in this situation, who will go after the diagonal, try to reopen it? And who would leave it because of the presence of, yes?
Not even because of the perforation. I would leave it because it's really heavily.
So for the record, this was subtotally occluded for so long. It was a bonus that we opened it, but because of the complication,
So here's
we left
a
it to leave it
question.
alone.
We could not deliver a covered stent. And there is 2 options in this situation. If you need to see the artery, you could embolize something to it, or in this situation, it's closed down. So would you go after it and open it? There's going to be still a debate. The patient is stable, not having chest pain. This artery was previously subtotally or totally occluded, and therefore there's going to be some collateral filling up later. So, with part of the process.
So this is the final run of
You
IVUS.
see here is mild disease, and this is a stent, the distal edge. There is no dissection, and you see well-opposed stent, good sizing, and no protrusion, going more proximally. And there's an area here that need more ballooning that we're gonna plan to go with the 3.5 NC. And here is the overlapping area between the 2 stents. You see the 2 stents coming up.
So this is the echo that we did bedside when we had the perforation, and we did it again at the end of the procedure. We can show you there was no significant pericardial effusion. Even though we had the perforation, we had the control of it right away. And we did not go after the diagonal. We stented the LAD, optimized the LAD. That was the main reason we were doing the procedure and the aim for it. The patient stayed in the CCU for 1 day, then we moved to the ward after that. He did a good recovery, no issues. We didn't need to take him back to the cath lab again. And basically, it was an unexpected complication, but hopefully that did not change our course of the operation, and we still managed to deliver what we needed to deliver. And we thank you for your attention. I'm happy to receive any question.
Great case. Go ahead.
Assalamu alaikum, Dr. Abdulrahman, Dr. Faisal. I mean, it's a great case. Very. You did exactly what you should. I mean, you solved your complication in a very smart and quick way. My question to you is whether you needed even to think about the diagonal from the beginning. I mean, I would have gone and just opened the LAD, fix it, put a stent, and if the diagonal is open, then khair baraka. If not, just leave it alone.
I agree with you. The simplest approach was, for that subtotal diagonal, to leave it alone. I always, if I managed to cross those branches and open them, and it could give the patient a better complete revascularization, I will do. Like in this situation, we had a very good result until then we got the ruptures. if the drug-eluting balloon worked fine and then we just stepped it and walked away and stented, it would be better for the patient. But you know, sometimes you aim to the sky, you land on the roof. So we'll take the roof here.
We'll take one more question because of timing. Go ahead.
Okay. Thank you, Abdulrahman. Nice achievement. My question is this patient turned down from surgery or not? There is a room for surgery for him or not?
So he's 80 plus, this patient. He was already had a stent in the proximal LAD. The diagonal is, the OM was a straightforward case. He just needed debulking for that. So I'm not sending a patient who's at this age for surgery just for a single vessel or two vessel in this situation.
Yeah, but the question in the beginning, if you want to start with the OM or you start with the LAD, this will make different if the patient he is
In what
candidate for
sense?
surgery. Because you have two-time failure to open this LAD. So you
But
start with the LAD.
that's failure, you have to remember. That's failure because there was no adequate equipment in certain places. They don't use rotablation, they don't have debulking. So unless you really do it appropriately as a complex, high-risk procedure where you have all the tools, you should not call it a failure, because if somebody does not have rotablation and they cannot open the artery because they don't have the right tools, it's not a failure of PCI, it's just they don't have the right tools for it.
Okay, thank you. So why you start with the OM? What you
So
support?
the OM, in order for me to have protection for myocardium, I normally start with the safest artery you have. You get better protection. You don't, if something happened with the LAD, your LCX is already there for you as a backup.
Okay, thank you.
Great case, Abdulrahman. Thanks for the demonstration, a complex case and job well done. This will conclude this session. Thanks.
Thank you all.